Assalamu alaikum. My name is Kinza Khan and my roll number is EP1770069. The main topic of my presentation is geriatric use of drug and the subtopic is geriatric depression, that is depression in older adults. First of all, what does geriatric drug use mean? It means the use of drug in elderly people or elderly population. Medications play a crucial role in geriatric health care as they treat chronic diseases, elevate pain, and improve quality of life. Depression, an illness that involves the body, mood, and thoughts, and that affects the way a person eats, sleeps, feels about himself or herself, and thinks about things. Depression is more than just a low mood. It's a serious condition that affects your physical and mental health. Prevalence of depression among older adults. According to the Centers for Disease Control and Prevention, depression affects about 1 to 5% of the general elderly population, 13.5% in elderly who require home health care, and 11.5% in older hospital patients. Here we can see that more than 10 to 11% elderly people are affected from depression. As the age increases, the number of cases of depression increases. Epidemiology of depression in elderly. At present, there are 322 million people with depression in the world. Near half of these people live in the Southeast Area region and Western Pacific region. Depression is more common among females, that is 20%, than males, that is 6.8%. Why do people get depressed? The reasons are emotionally painful events, past depression, low income, decrease in quality of lifestyle, declining health or physical illness, disabilities and limitations, lack of social contact, feelings of loneliness, side effects of medications. Causes and risk factors for depression. Several factors or a combination of factors may contribute to depression. Genes. People with a family history of depression may be more likely to develop it than those whose families do not have the illness. Personal history. Older adults who had depression when they were younger are more at risk for developing depression in late life than those who did not have the illness earlier in life. Brain chemistry. People with depression may have different brain chemistry than those without the illness. Stress. Loss of a loved one, a difficult relationship, or any stressful situation may trigger depression. Types of depression. There are several types of depressive disorders. Major depression. Major depression involves severe symptoms that interfere with the ability to work, sleep, study, eat, and enjoy life. An episode can occur only once in a person's lifetime, but more often a person has several episodes. Persistent depressive disorder. Persistent depressive disorder is a depressed mood that lasts for at least 2 years. A person diagnosed with persistent depressive disorder may have episodes of major depression along with periods of less severe symptoms, but symptoms must last for 2 years to be considered persistent depressive disorder. Other forms of depression include psychotic depression, postpartum depression, and seasonal affective disorder. Symptoms. According to the American Association for Geriatric Psychiatry, the most common symptoms of depression in the elderly include persistent sadness, feeling slowed down, excessive worries about finances and health problems, frequent tearfulness, feeling worthless or helpless, weight changes, difficulty sleeping, difficulty in concentrating, somatic complaints, withdrawal from social activities. Medical conditions and depression. Medical problems, including chronic medical conditions, can trigger or worsen the symptoms of depression in elderly patients. Any medical condition, especially those that are painful, debilitating, or life threatening, can result in symptoms of depression, including cancer, Parkinson's disease, stroke, heart disease, lupus, diabetes, dementia, and Alzheimer's, multiple sclerosis, or even we can say hypertension. Medication and depression. Certain medications are associated with depression in elderly adults. These medications include cardiovascular drugs, chemotherapeutics, antipsychotic drugs, anti-anxiety medication and sedatives, anticonvulsants, anti-inflammatory, anti-infective agents, stimulants, hormone drugs, and other drugs. Elderly patients who experience depressive symptoms when taking medications should report symptoms to the prescribing physician immediately. Treatment strategies. Effective treatment of depression in older adults can require more than one approach. Psychotherapy. Psychotherapy includes ongoing talk therapy, can be a source of support for Elderly patients. Cognitive behavioral therapy can also be effective in helping elderly patients. Support groups. Support groups designed to connect older adults experiencing similar issues, that is depression, medical condition, etc., are beneficial in establishing social support and providing a safe space to talk. Lifestyle changes, daily exercise, healthy eating habits, increasing social support, and medication that is recommended are antidepressants. Mechanism of actions of antidepressants. The antidepressants inhibit reuptake of neurotransmitters through selective receptors, thereby increasing the concentration of specific neurotransmitter around the nerves in the brain. Antidepressants and their classifications: tricyclic antidepressants, selective serotonin reuptake inhibitors, uh, that is more commonly used in the elderly patients in low doses. Then monoamine oxidase inhibitors, serotonin norepinephrine reuptake inhibitors, and non-TCA antidepressants. SS, SSRIs inhibit the reuptake of serotonin at the presynaptic neuronal membrane. The drugs include citalopram, sertraline, paroxetine, escitalopram, fluoxetine. Uh, Serotonin norepinephrine reuptake inhibitors inhibit reuptake of both serotonin and norepinephrine, weakly inhibit dopamine reuptake. Monoamine oxidase inhibitors competitively inhibit monoamine oxidase. Agents in the class differ in their reversibility and their activity against monoamine oxidase A and monoamine oxidase B. Serotonin modulators, selective inhibitor of serotonin reuptake, also act as a 5-HT2 antagonist. Dopamine and norepinephrine reuptake inhibitors inhibit dopamine reuptake with some effect on norepinephrine. Noradrenergic and specific serotonergic antidepressants block presynaptic central alpha to adrenergic autoreceptors, resulting in increased neurotransmission of noradrenaline and serotonin. Also block postsynaptic 5-HT2 and 5-HT3 receptors. Tricyclic antidepressants inhibit reuptake of norepinephrine and serotonin into presynaptic terminals. Among all of these, the mostly preferred drugs in the elderly patients are selective serotonin reuptake inhibitors. Soap node. JW is a married woman. Her age is about 79-year-old, and her height is 5'8". Her weight is 110 lb. Who presents for a psychiatric evaluation. Her husband says she just has not been herself lately. The changes in JW began on a family vacation 6 months earlier when she got lost on the cruise ship. Since that incident, she has become increasingly anxious and has developed insomnia. Although she does not feel sad or depressed, she generally does not feel well. JW's normally positive attitude toward life has become pessimistic. Her husband confirms that she has become more forgetful and no longer enjoys eating. In fact, she has lost 18 lb over the past 2 months. JW no longer does her volunteer work at the local children's center. She says she wants to die because she is no longer the person she used to be. But she denies having any specific suicidal thoughts. Her medical history is significant for diabetes and hypertension, which are both well controlled on glipizide 5 mg QAM and HCTs at 25 mg QD. Her medical evaluation and physical examinations are unremarkable. Laboratory results and head CT scan are within normal limits. JW is diagnosed as having a major depressive episode. What symptoms of depression are present in JW? Now moving towards the patient's clinical profile, the name is JW, age is 79 years old, gender female, weight is 110 lb, and height is 5'8". Subject: presenting complaint, increasingly anxious and has developed insomnia, pessimistic attitude towards life, forgetful, and no longer enjoys eating. History of presenting complaint: on a family vacation 6 months earlier, she got lost on the cruise ship. Medical history and recent significant for diabetes and hypertension that can trigger the symptoms of depression. And the recent situation is that she is going through with major depressive episodes. Medications that she was taking because of the medical history: glipizide 5 mg QAM. QAM means that once every morning. Every morning she has to take glipizide and hydrochlorothiazide 25 mg. QD means that once a day. Objective: laboratory results and head CT scan are within normal limits. Management of depressive episodes with antidepressants or any psychotherapy can be done. Assessment: diagnosis: she is diagnosed as having major depressive episodes because of being pessimistic towards the life, problem in sleeping, loss of interest in activities and socializing, and because she is feeling down and hopeless on regular basis. Physical examination shows that she has lost 18 lb over the past 2 months. Plan: antidepressants are recommended. Selection of an antidepressant drug for elderly patients must take into consideration age-related changes in pharmacokinetic, pharmacodynamic, and physiological parameters that make this population more vulnerable to adverse effects. Although the available antidepressants are about equally effective, selective serotonin reuptake inhibitors are better tolerated than older agents such as the tricyclic antidepressants. Therefore, low-dose SSRIs should be considered first-line therapy for most older patients. JW should start taking a low-dose SSRI with gradual dose titration to achieve control of her depressive symptoms. It may take 8 to 12 weeks before assessment of JW's full response can be made. She can also continue the drugs for diabetes and hypertension. The SSRIs include citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline. These all can be given with different doses and with the patient's requirement and situations. These are all the references. Thank you so much.